Hi everybody. Thank you so much for coming today when it's completely gorgeous outside. I appreciate it. So I am going to focus on kind of detecting anxiety disorders today, but I do a lot on treatment as well. My new research focus is traumatic stress in individuals on the spectrum. So if you have questions about that, you want to talk about that, we can definitely go there towards the end of the talk. And just to give you a little bit about my background, before I even went to grad school for clinical psychology, I was a research coordinator of a genetic study of autism, where basically my job was to drive around all the greater New York City area. I actually had to learn how to drive for this job because I grew up in Manhattan and I did not have a license. So I learned to drive, and I would drive all around within 100 miles of New York, visiting families that had a minimum of 2, 4 or 5 kids on the spectrum, and characterizing those kids for these genetic studies. So I learned the ADOS, I learned the ADI, and it just got me really interested in autism. And I also noticed while working with those kids what I thought was a lot of anxiety that wasn't necessarily being called anxiety. So it was all just kind of autism. And so this led me in my doctoral training to go and work with an expert in child anxiety disorders and kind of take what I could from that world and apply it to kids on the spectrum to better understand, when do we even think a kid with autism has an anxiety disorder, and what does that mean in terms of treatment implications and the validity of the measures that we're using that have been developed for kids without autism but which are applied to this population. Okay, so that's a little bit of my background. And just funding and disclosures, just want to disclose who's given me money to do this work, and I also want to let you guys know that I'm going to be talking about an adapted version of the anxiety disorders interview schedule today. It's a semi-structured clinical interview. Most of the research I'm presenting was done before anybody ever gave me any money to train them on this tool, but I do want you to know that at this point I am consulting with different universities throughout Canada and the US and in the UK, training them on this approach, and when I'm involved in those studies, they typically pay me for my time. So you should know that, okay? All right, so anxiety and autism. Why is anxiety a prevalent and potentially impactful treatment target in autism? So my next few slides are my effort to convince you that this is an important topic, which maybe we're all on board with already because you're here, but let's just go through. And I want to thank Karen Bopp and Tony Bailey for this slide. So Tony sent this my way and then told me that Karen actually created it. But I just want to emphasize and use these statistics from BC that the prevalence of autism is rising. In BC, the estimate right now is 1 in 58. That's pretty high. That's actually right where the most recent estimate from the US is. And we see that that's been a steadily increasing number over the past 10, 15 years at this point. The data from the US study suggests that this is particularly an increase in cases that don't have co-occurring intellectual disability, so cases that may be less severe, which is potentially interesting when we think about who are the kids who are most likely to have anxiety or who we're likely to catch anxiety in, okay? So what is important to me about this prevalence and what's important about autism research is, of course, we want to understand what causes autism, what are the best ways to intervene and help kids on the spectrum, but we also need to think about, not only in terms of preventing autism or treating autism, how do we help people with autism have a better quality of life, live a fuller life, and reduce their distress over the course of their life right now, okay? This is pretty important, particularly given the number of children and adults who are going to be on the autism spectrum in our population. So that's where anxiety comes in and potentially can play a pretty big role in terms of improving quality of life and functioning of youth on the spectrum and their families throughout the lifespan. So just some overall statistics. We know anxiety disorders in kids on the spectrum are pretty prevalent. The range is 11 to 84%. Good. This is when I check if you're listening. This is not a great range. It's almost like saying 0 to 100, so we're going to talk about that. If you look at some of the better studies, so studies that are based on community samples as opposed to clinic samples, even population-based samples and meta-analyses, the range seems to be more around 40%, okay? This is still significantly higher than we see in kids with intellectual disability, Williams syndrome, conduct disorder, a variety of other kind of at-risk children's specific language impairments. Rates of anxiety are higher in kids on the spectrum than those other groups. And we also see that anxiety, when it co-occurs with autism, is associated with a lot of additional difficulties, okay? Not broadly everything is worse, but specifically, some things are worse, okay? So it's not as simple as saying 2 disorders is worse than 1. We can't be that basic about it. However, there is research to suggest that kids with autism and anxiety have more trouble getting adequate care, coordinated care, and their families are more dissatisfied with the care that they receive. They're more likely to have self-injurious behavior, more depression, more family stress. Their families are extremely worried about their ability to live independently and function as adults, even in kids who have actually high IQ. Okay, so the anxiety is actually causing a lot of stress and problems in the family on top of what might be kind of deficits that we're associating with autism itself. We also see more gastrointestinal symptoms and certain types of social difficulties. So not all social skills will be worse in some kids with anxiety and autism, but we do see less ability to kind of engage or kind of pro-social behaviors. Another thing when you're talking about anything that occurs in 40% or more of your population is that potentially this is a whole lot of noise for your research data that you would want to be aware of. Okay? So when we're doing studies of autism and we want to know about cognition in autism or the amygdala in autism or physiological data in autism, even school testing, right? Probably want to know if those kids with autism have anxiety or not, because anxiety influences every single one of those things. Amygdala, cognitive performance on something like a Wechsler, a DOS, whatever your choice is, all of these things, resting state arrhythmia. So a lot of things, variables that we look at in autism, genetics, right? We would want to know what is anxiety a part of this particular picture and what is it potentially contributing to our research results. Particularly when you look at research in autism, we saw a lot of conflicting things, so anxiety might be a key piece. And finally, as problematic as it is, anxiety is potentially a problem with a lot of promise because we actually have quite effective therapies for child anxiety disorder, okay? The one that particularly stands out is cognitive behavioral therapy. Which is very effective for children with autism, but actually we're also seeing good effects for kids on the spectrum who have verbal abilities. So recent meta-analysis conducted by Danny Young found basically moderate treatment effects for kids with autism and anxiety and verbal ability. CBT really improves the anxiety post-treatment. They're treatment responders. We'll talk more about this at the end. You need to keep in mind that treatment responder doesn't always mean you have no anxiety disorder at the end. Okay? So sometimes these trials are talking about degree of change in severity. You might still actually have an anxiety disorder at the end, so your anxiety is still higher than other people, but it's nowhere close to where it was before. So just something to keep in mind. Across studies, you can see up to 71% response rate in these studies. And then also not to only focus on higher functioning kids or kids with verbal ability. Tamara Rosen actually did a review of single subject design studies that had looked at treatments of phobic avoidance and also found that there seemed to be some effective treatments related to desensitization in kind of treating anxiety in that population as well. Okay? All right. And then I always like to touch on this point for a moment. This is the little engine that could. It's a story from my childhood. It might be dating. I might be dating myself. But do we all know the story of the little engine that could, right? I think I can, I think I can, I think I can. You get over the mountain, okay? The reason I present the little engine that could is because it's important to keep in mind that kids with anxiety are the kids who really think that they can't, okay? And we all face adversities in our life and challenges. That may be particularly true for kids on the spectrum, okay? They have a lot of adversities coming their way. And a key variable there about being able to get over the mountain is the ability to at least entertain in your mind that you can, right? Anxiety is the type of thing that stops you dead in your tracks. And that is hugely important when we think about this population that is potentially going to face more challenges, that we need to engage with us in treatment, right? And who we want to develop coping skills about how to kind of deal with those challenges in their life. There's also a key difference that's talked about a lot in acceptance and commitment therapy and mindfulness, between this difference between pain and suffering, okay? So you can have a lot of pain and injury in your life, but suffering is the thing that we add on top of that, right? It's our struggle against the pain. And I think anxiety inhabits this space as well. So when we're talking about anxiety, we're talking about kids suffering with the challenges in their life, and we want to try and do something about that if we at all possibly can. All right, now I'm going to get into research findings, okay? So I want to talk to you about a series of studies that we've done to really try and look at the anxiety and autism literature and ask this question about, okay, what do we even call, how do we define anxiety in kids on the spectrum, and how does that influence our results in the research as a result, okay? And this is all based, it kind of originated from a review that I wrote in 2012 with Phil Kendall, where we did a systematic review of the literature and really looked at what's the presentation, how do we classify anxiety in kids on the spectrum. So I'll be presenting a lot of data from that. And it was responded to, thankfully, positively by many people in the field. So I didn't know that they were writing these commentaries. It was quite terrifying for me. I was in grad school at the time. But thankfully, there was some consensus about some of the ideas and the questions raised. Okay. So this is where I'm going to get back to 11 to 84%. And the main message of this slide is conflicting results. Okay. So over the past 10, 15 years, I think we've moved away from diagnostic overshadowing. Okay. So diagnostic overshadowing is this idea of we don't see the anxiety because we only see autism. Autism becomes this huge umbrella that encapsulates all other difficulties, and so they don't get recognized. 20 years ago, there were almost no studies on anxiety in kids with autism. That is no longer the case. There's been a huge burgeoning of interest on this topic in the last 10 to 15 years. Despite that increased interest, we are seeing not necessarily a convergence of findings, but a little bit of findings all over the place. And I think that's easiest to illustrate in this prevalence range of 11 to 84%, which, as I said, is really not saying too much. Okay? Now, there are many reasons for broad ranges like this: the quality of the study, the type of assessment that you're using. Is it one question that you're asking parents about what they've been told by their doctors? Is it a questionnaire? Is it a semi-structured clinical interview with an expert? Those things can all influence it. The age of the sample. But another thing that we have to think about is how do we define anxiety disorder and what it looks like in this population, particularly given all the overlap of anxiety and autism symptoms. Okay? In addition to this broad prevalence range, you will see that there's really no consensus about what the most common anxiety disorder is in this population. You can kind of go find what you want. If you were to do a Google search and you wanted to say, I want to write about OCD, you could go find that article that says OCD is the most prevalent. If you wanted to write about social, you could go and find social anxiety is the most prevalent. There's not consistent findings. There's also not a lot of consistency about the associated characteristics of anxiety in this population. So for example, some studies suggest higher IQ, better verbal ability potentially, more anxiety. You can express your anxiety. Maybe you have more cognitive ability to have anxiety. Some studies show that association. Other studies find no association between IQ and anxiety. And the meta-analysis that I referred to before actually concluded that lower IQ was associated with anxiety in this population. It's all over the place. Similarly with autism severity. So thankfully, no studies are really reporting high correlations of 0.8 or 0.9 saying that these aren't distinct constructs. They do seem to be distinct constructs. But some studies will say more autism symptoms, more anxiety symptoms. Others find no relationship. Still, others would say that less autism symptoms in terms of being more socially motivated, more engaged, right? Less autism symptoms would be a risk factor for anxiety, because if you're less socially engaged, if you're more socially engaged, you're more likely to be worried about what other people think and upset about being separated, right? Separation anxiety. It's all over the place. So part of what's going on here are methodological issues, but what I also want to emphasize to you guys today is that part of what potentially is going on here is a differential diagnosis issue. So, and I want to try and convey to you just how difficult it is when you sit down with a parent of a kid on the spectrum. Maybe you already have this experience or you're evaluating a kid on the spectrum. Sometimes to make this decision, is this kid really anxious or not? Do I think that they have an anxiety disorder that's worth giving a second diagnosis here in addition to what they're kind of encountering, right? It's not easy. There's a lot of overlapping symptoms. We're dealing with an issue here of something I mentioned before, which is that for the this has recently changed. Last couple of years, we've got some new measures. I'll talk to you about one today. But up until the last few years, we were relying entirely on measures designed for neurotypical kids and normed and standardized on neurotypical kids to understand anxiety in this population. Although there's many reasons to think that maybe kids on the spectrum, it's harder to see the anxiety or it might express in different ways. And then finally, even when we take our most fine-grained approach, so let's say clinical interviewing, really sitting down and doing the best job you can to figure out anxiety or autism, people haven't actually necessarily been consistent in their operational definitions or their guidelines for differential diagnosis. Okay? I'll talk about this a little bit more. I got a Rorschach here, which my CBT mentor would not be happy about, but whatever. And also kind of all the overlapping circles here. This slide is just to illustrate or emphasize, right, that there's a lot of overlapping symptoms between autism and anxiety itself. Okay? Just to name a few, perseverative or rigid thinking, black and white thinking, is a symptom of anxiety. When people get really anxious, they tend to get really rigid. Okay. Repetitive and ritualistic behavior, huge areas of overlap between OCD and ASD. So what makes a repetitive behavior a ritual that's characteristic of OCD versus a repetitive behavior that's an autism repetitive behavior, particularly when actually verbal rituals are built into the ADIR, which is an autism diagnostic interview. Okay. Social avoidance, this is a fun one. We'll talk a lot about it, right? Social avoidance is in a lot of social anxiety measures because the assumption is if you're avoiding social situations, it's because you're afraid of it. But that is not often always the case for kids on the spectrum, right? So when you see social avoidance in a kid on the spectrum, how do you interpret it? Sleep difficulties, inattention, restlessness, GI problems. These are all things associated with anxiety, particularly generalized anxiety. They're also things that are sometimes there from day one for kids on the spectrum, right? So how do we use those things to look for anxiety in this population in a careful way? We have to think about developmental considerations. So part of what makes anxiety an anxiety disorder, as opposed to just normative appropriate anxiety, is how does it match kind of the other fears, typical fears of kids that same age, okay? So kids on the spectrum are also developmentally quite different, right? And sometimes you can't even say, well, he's got more of the cognitive ability or the developmental age of a 2-year-old because that's only true for one domain, and the other domain is actually equivalent to a 5-year-old, right? Splintered skills. So how do we think about that child's developmental age and what does it say about how appropriate or inappropriate their anxiety is, okay? Impaired communication. A lot of anxiety symptoms are verbally mediated. I was worried about this. What if this? My child was worried about, okay? Some kids on the spectrum don't speak. Okay? So this means we have to go entirely on their behavior to try and interpret anxiety. Even kids on the spectrum who have a lot of language aren't necessarily good about talking emotions, right? Identifying their own emotions. So just because they can talk a lot doesn't mean actually that they've talked to their parents about what they're afraid of or why they're having a meltdown, right? So we rely a lot on parents inferring meaning about behavior, and we actually as clinicians are doing the same thing, okay? And then finally, there is, I think, accumulating research to suggest now that there are distinct kind of manifestations potentially of anxiety in this population. So ways that fears are expressed, things that you're afraid of that don't fit neatly into DSM categories and look a bit distinct from the anxiety that children without autism experience. And to illustrate this to you, this is always a little hard to describe, but I like to go back to Kanner in 1943. Now, there are many limitations to this old paper, okay? If you read the whole paper, do so with a grain of salt. Many of his ideas are outdated. However, one great thing about the paper is he has these rich clinical descriptions. And remember, this was the paper that's like the seminal paper. This is where autism was described. And if you look at it, you see what I think sound like potentially anxiety symptoms, or at least bring up the complexity that I'm trying to convey, okay? So case number 1 was named Donald, and Connor says the father talks about how we brought him to a playground slide. When other children were sliding on it, he would not get on it. He seemed horror-struck, okay? Horror-struck suggests anxiety, okay? But I have a lot of questions hearing about Donald here, right? Is it truly anxiety, Or is he annoyed that these other children have taken over his space, right? Is he afraid? In social anxiety, we're also often thinking about fears of negative evaluation. Will people reject me? Will they dislike me? Will they laugh at me? Many kids on the spectrum do not have that concept, right? They don't have great theory of mind. That's not what they're worrying about, and yet they seem quite terrified, horror-struck in social situations. So what do we do with that? Okay. Barbara, very timid and fearful of various changing things. But what are the things? Wind, large animals, running water, gas burners, and many other things. So here's where we see those kind of idiosyncratic, unusual phobias, which again are included in some diagnostic instruments for autism, and yet seem also to be phobias, right? But the focus of the fear is different. Alfred, he describes a good deal of worrying. Worrying might cue us up to think about generalized anxiety disorder, right? But what is Alfred worrying about? He frets when the bread is put in the oven to be made into toast. He is afraid it will get burned and be hurt. He is upset because the moon does not always appear at the sky at night. So here we have a description of worry that also is very closely overlaid, right, with these insistence on sameness, negative reactions to change, which are quite core to how we think about autism itself. Okay? And finally, John, marked obsessiveness. We could think OCD. When we hear that word, his daily routine must be adhered to rigidly. Any slightest change calls forth bursts of panic. Okay, we could even think panic disorder here. So the question is, though, when we see that, are we truly seeing OCD in John? Are we going to diagnose OCD? Or do we think this is more kind of just autism itself? And how have clinicians and researchers been approaching that very difficult line and how we draw it across the research? And so that all my references are not based on something from 1943, I just want to include, and you guys will have this in your packets as well, these are more recent qualitative studies that have been done, and there are actually a number of them that have been done now, talking to adults on the spectrum, teenagers, parents, and clinicians who work with kids on the spectrum about what are sources of anxiety and ways that anxiety is expressed in this population, and you will see many of these themes reiterated here. So we have a more recent reference for anxiety may not always display in these kind of classic DSM neurotypical types. Okay. All right. So this picture may be familiar to some folks. It's called My Wife and My Mother-in-Law. Okay. So you're either going to see a lovely young woman with a fur coat on, and she's got a feather in her cap, and this is the side of her face, right? Or you're going to see the mother-in-law, and this is not very positive, who's got a bigger nose and a frowning face. Do you see? It can go both ways. We all getting it? Do you see both sides? Yeah? Okay. I include it just to underscore. We could be looking at the exact same thing and see something totally different, right? And this is the case with these overlapping, potentially ambiguous features in kids on the spectrum, saying, is it autism or is it anxiety? One person might look at it and say, oh, that's autism. Another might say, I think that's an anxiety disorder, okay? And this is just a review of studies that actually used a clinical interview. So again, not just a questionnaire, a clinician who is trained to a certain criteria and actually interviewing a parent and trying to get the best information they possibly could. And even within those studies, you'll see big differences in the range. So for example, OCD has been estimated between 6 and 37% across studies. Muris in 1998 noted that if they had counted all ritualistic behavior in kids on the spectrum as OCD, they could have estimated OCD as 73% in that sample, right? So clearly we don't want to count all ritualistic behavior as OCD. And you're going to see the lowest rates when the interviewer required the parent to identify some kind of intrusive, distressing image that the compulsion was related to. If you put that criteria in, it's going to drop down the rate of what's endorsed significantly. Social phobia, 8 to 29%. Again, you're going to see the lower rates when they require fear of negative evaluation as part of if we're giving this diagnosis. If you're just going to look at social avoidance, the rate will go higher. Okay? So you can see these differences even in these clinical interviews where people are really taking time. They can still make different decisions about what they want to do with that social avoidance or how strict they want to be about the criteria. Okay. So in going through all of this literature, we basically put forth kind of some hypotheses about what could be going on here and the categorization, classification of anxiety in kids on the spectrum. So there are three things I want you to think about. One is the possibility of comorbidity. And I'm going to use comorbidity in a very strict way, which is this is a disorder that is expressed the same way comorbidly as it is monomorbidly. So this means that anxiety is a separate disorder from autism itself and is expressed in the same way in kids with autism as it is without. Okay? This is kind of a scientific, rigid definition. So as when I say comorbidity, that's what I mean. There's also the possibility of all these report of anxiety in autism. A good section of it is potentially misclassification. So this is just social avoidance or repetitive behavior in ASD that's been misclassified, misinterpreted as anxiety. And then another possibility is that of variation, right? Which is that maybe it is co-occurring to anxiety. Maybe this is something separate. But the quality of it, the way it's expressed, is influenced by autism itself, right? So it's got a particular flair to it. And that's kind of what we proposed, is that what is going on here is that there are both truly comorbid traditional anxiety disorders in this population, and there are more distinct and ambiguous presentations, okay? The comorbid disorders we expected would be more associated with things like verbal IQ or language ability. So if it's going to look a lot just like GAD in kids without autism, you probably need some language in order for that to be there. More associated with worry and social connectedness. And then these more distinct and ambiguous features, which could potentially fall into either one of these categories. So this is kind of what's under debate. Are they anxiety, the quality of which is changed by the co-occurrence with autism itself? Or are they actually just, these are just autism symptoms, they're not anxiety, we're making a mistake by calling them that way, okay? And I'm thinking here of like Kanner's original descriptions that I went through with you guys. So that phobia of water running down the drain, phobia of men with beards. This is one that comes up a lot. Kanner talked about it, phobia of toilets, and it can be the sounds, specific sounds, so not in trouble with loud sounds, but specific tones. Those are kind of classic things we associate with autism. This is a question of, could it actually be anxiety layered on top of autism? This is what anxiety looks like in autism, or just a feature of autism itself. Okay, so once we hypothesized that, we also kind of set out to try and now investigate this. So the first study we looked at to do this was using a sample from Children's Hospital of Philadelphia in collaboration with Temple University. And these were 59 kids who were actually recruited for imaging studies of autism. So they weren't selected for anxiety, and we didn't recruit for anxiety in our flyers. They were coming in for an imaging study. This means that the IQ, we had a good IQ range, 67 to 158, but it's not the full IQ range, okay? And all of these kids had verbal ability because we actually interviewed both them and their parents for this study, okay? 7 to 17 years, mean age of 10. They were predominantly male, white, and from moderate to high SES families. That was true of these neuroimaging studies at CHOP at the time. And 50% were taking psychotropic medication. And so what we did is these kids had already been very well characterized for the imaging studies in terms of ASD and cognitive ability. And then we did a semi-structured interview, the anxiety disorders interview schedule, which we adapted and expanded specifically for this population. Hi. Come on. It's okay. So these are the measures that were included in terms of their original ASD characterization, the self, a language measure, the sensory profile, the DOS for IQ. We also had them do a self-report questionnaire called the NASQ, which actually assesses cognitive style. So it's like, how do you kind of think about things? And there's an anxiety subscale that tends to pull out or detect kids with anxiety disorders. And then we did this expanded ADIS. And I'm going to take several slides to talk to you about what this really looked like. But just to give you the basic specs on the instrument, it's a clinical interview where one clinician interviews parent, another clinician interviews the child. They go through the same modules, and you're going to go through all the DSM, and this time it was 4 anxiety disorders, and assess all of those criteria. And then each module, each disorder is given a rating from 0 to 8, with 8 being the most severe. This is, child needs to be hospitalized because their OCD is so impairing, right? And 0 being like, this is not here at all. Not a problem. 4 is the cut point where we think this is a disorder, okay? So, and then based on child or parent report, we take the highest rating. Okay, so it's either or. What we did for this study is we gave the clinicians systematic guidelines. So here's what to do with social avoidance. Here's some rules to follow. I shouldn't say rules, guidelines, okay? Here's what we want you to think about in terms of differentiating social versus social avoidance versus actually related to autism versus fear. Sensory sensitivity versus phobias, or their relationship. We gave them guidelines, and then we also allowed them to give these clinical severity ratings, which are typically just given for the DSM anxiety disorders, to distinct presentations of anxiety. So we let the parents tell us what they were seeing, and when it didn't just fit into the normal category, we said, okay, let's write about that and tell us what the severity of that is. Okay? So it gave us this way of kind of seeing what are these different presentations of anxiety in kids on the spectrum and measuring them, as opposed to just dumping them into the DSM categories or calling it autism, which is essentially losing that data. So we have no way to really look at what's contributing to the picture or how it's different from autism or anxiety if we do that. So we were able to measure it separately. Okay? And I'm going to do a little clinical interlude to talk about what this diagnostic process actually looked like and how we make these decisions or advise people to try and make the decisions about anxiety or autism. So the first thing to keep in mind when we're just thinking about diagnosing anxiety disorders is anxiety is adaptive, right? So if you don't have enough anxiety, that's a problem. It's as big a problem as having too much anxiety. And even in treatment, we're never trying to take away all anxiety. We're just trying to turn the dial down, okay? And it's important to remember that actually 70% of kids say that they worry now and then, and that doesn't translate to anxiety disorder. It's for example, it was important for me to get somewhat anxious about giving this talk today so that I prepared it and I was ready to say things to you, right? If I had no anxiety, then maybe I wouldn't do as good a job, right? You don't actually, if you have too much anxiety, then you become frozen in place, stuck in your tracks, and you can't do it either. So we're always looking for adaptive, within the adaptive range. And anxiety disorder is when that protective mechanism, that thing that's put in place to keep us from petting a lion or walking in front of a Mack truck, when it becomes maladaptive, right? And instead of protecting us, it's actually keeping us from doing the things we need to do. So that's our general framework for anxiety disorder versus not. And then here are the main kind of anxiety disorders we looked at that are most common in children: separation anxiety, social phobia or social anxiety, generalized anxiety, and specific phobias. And here, I'm going to go over these in more detail, so I'm going to go through them quickly now. But here are some of the key kind of differential item information that you need, I think, to think about, is this anxiety disorder truly there? How do we differentiate it from autism deficits, for example, that might make the anxiety appropriate as opposed to inappropriate, right? And what do we do with kind of quirky or more idiosyncratic distinct fears that come up in this population? So as an illustration, social anxiety disorder, okay? Symptoms of social anxiety disorder are expressing fear, social ridicule, rejection. People will make fun of me. I'll embarrass myself. I'll get laughed at. They won't like me, right? It's typically characterized by social avoidance and social difficulties. And it can be both specific and generalized. So you can have just social anxiety about speaking in front of people, okay? Or you could be worried about most social interactions, talking to somebody you've never met before, even letting your friends get to know you well, because it would be scary for them to know who you really are. Okay? So in autism, when we're thinking about diagnosing social anxiety disorder, we have to keep a couple of things in mind. Number one, what is actually the base level of social motivation that this child has? Okay? So in this expanded interview, the clinicians actually assess these kind of key differential items. So they have this information before they even ask about social anxiety. So we want to know, how interested in this kid is this kid in being with other people, right? Because that's kind of important for us to then interpret how much social anxiety or fears of other people might be getting in the way of their social functioning, okay? What we don't want to do is attribute all social difficulties to social anxiety in a kid on the spectrum, right? Because that's probably given too much credit to the anxiety, right? And there are many kids on the spectrum whose social motivation is lower, right? They are not that interested in hanging out or being around with other kids. They really want to do their own thing. There are also kids, and I've seen plenty of them, who are standing at their window, gazing down at the street where kids are playing and wishing desperately that they were there and that they were involved. And they try, and they're not successful, right? But they wish They wish that they could be doing that, and they want to know why they don't have more friends. We see the full range. We need to know which kid we're talking about before we assess kind of traditional social anxiety, and we try and figure out how much impairment is actually due to this anxiety as opposed to a social skill deficit. Bullying and peer rejection. Why might this be important? Well, why might it be important for us to know how badly this kid is being bullied or how terribly they've been rejected, particularly if they're on the spectrum, before we assess and determine how pathological their social anxiety is?
Because if we think about anxiety as something that might be adaptive for a child who going to school means that they're going to be bullied and rejected, it might actually be adaptive to have a bit of anxiety about that situation.
Right. So if you're a kid on the spectrum and your worry is, I won't know what to say, what if I say the wrong thing and they laugh at me, okay? That's not necessarily a maladaptive, excessive, or inappropriate thought. That may be a really legitimate thought, okay? And we need to think about that before we diagnose all these kids with social anxiety disorder, okay? Because it could be that they're actually having pretty appropriate normative responses to tough social situations. At the same time, there are also kids who maybe they have had a bad bullying history, right? Maybe they have been rejected. Now they're in a pretty supportive social environment. Maybe they even want to go to a social skills class, right? And they can't get through the door because they're so terrified of what other people might think or say or do, okay? This is an example of where maybe what started as adaptive and realistic response has now ballooned, and we are now looking at anxiety disorder. Another way to think about this is a fear not just of peers who have been teasing them, right? But of any peer, or also adults, or letting anybody hear your voice, okay? So these are some of the things that we see that really go along with social anxiety that go beyond what might be appropriate given if you do actually have social difficulties. But we want to know what are the level of social difficulties here, what is this kid facing before we pathologize their reaction, okay? Theory of mind and social awareness. This is kind of going back to what I was mentioning before. A big part of social anxiety disorder is this idea of what do other people think about me? Some kids on the spectrum don't have great theory of mind abilities, okay? So this whole concept of other people are thinking things about me is not even there yet, okay? And yet, if they appear petrified, they're shaking and they're trying to escape social situations, they're hiding their heads, do we say they don't have social anxiety because they're missing this fear evaluation? Is it a distinct presentation, right? What do we do with that? So we want this information because if it's truly going to be social anxiety disorder, there probably is some fear of other people won't like me or I'll be rejected, think I'm dumb, etc. And if there isn't, but we see a lot of behavioral manifestation of anxiety or clear fear response, maybe that's where we want to capture in this kind of distinct category, okay? What are their social opportunities? So before you kind of ding them for not having a lot of social interaction, what are the social opportunities they have? What kind of classroom are they in? And also, what's the timeline of this? So for example, what has happened to their social motivation over time? Can be very useful to think about. This is a kid who used to be socially motivated and now he's not after experiencing a lot of rejection, right? That's more of a social anxiety profile than actually getting more socially interested with time. Okay? So I'll keep going. But this is kind of where this other presentation of being fearful despite kind of low social motivation or low theories of mind, that's what we'd call kind of a distinct other social fear presentation that we measure with this ADIS. And you see this again in the qualitative studies where adults will talk about having anxiety related to just confusion in social settings. So it's not that I'm afraid what people are going to think about me, it's just I don't know what's going to happen. I can't predict what's going to happen in social situations, so it's overwhelming for me. Or just anxiety in general about making eye contact, adjusting behavior, comprehending the social situation. Okay? We're also going to be looking at the specific and idiosyncratic phobias. So these are things like general sensitivity to stimuli. So if you have a kid who's generally sensitive, for example, to loud sounds, what do you do when you say it's time to go to the bathroom and they think that there's an automatic flusher in there and they scream and run away, okay? Is that just a sensory sensitivity or do we want to code that as anxiety disorder as well, okay? So how do you think about response to something that maybe actually physically hurts them versus actually a phobic anxious reaction, okay? We gather specific data on what is their sensory sensitivity before we go into that phobia question so we can try and assess. A good way to think about this is if a kid is afraid of fire alarms, for example, when the fire alarm goes off, or sorry, they have a sensitivity to fire alarms, they're going to cover their ears and cry and want to leave. That's sensory sensitivity. The kid with the phobia is the kid who won't go in the building because there might be a fire alarm, okay? Or some other examples from patients I've seen, they are checking with the principal multiple times a day. Will there be a fire alarm today, right? Need constant reassurance. When you take them to a new place, they case the joint. Where are the fire alarms, okay? So this is an example of not just the reaction, the sensitivity to the sound, but actually anxiety, fearful anticipation that that sound's going to happen. And we want to look for is that fearful anticipation actually impairing their life, okay? Which it can. If you can't go into school, you don't want to go into a hospital, you don't want to go into certain stores with your mom because you're afraid of the loudspeakers, maybe the loudspeaker will go on. Or an idiosyncratic phobia. One of my patients had a fear of the song Soul Sister by Train, which is kind of an old song now. It was very annoying. They used to play it on the radio all the time. But he was very afraid to go to any place where there might be a loudspeaker because they might play this song, okay? He didn't have a trouble with loud sounds. I would have a bullhorn in session and we'd be laughing, okay? Putting this bullhorn, making loud sounds together. It wasn't loud sounds, it was this specific sound. And it was quite terrifying to him, okay? All right, generalized anxiety disorder. I'm not saying Woody Allen has it. I'm saying he often portrays people with GAD-type tendencies in movies, okay? This is like worry du jour, worries about performance, worries about the future. Will I be homeless? Global warming, politics, and like a 6-year-old, illness, school, crime. If it's not one thing, it's another, okay? You might see a reduced willingness to try new things. Challenges and intolerance of uncertainty, sleep disturbance, somatic symptoms. So that's GAD. What we have to deal with in autism is perseveration and worry. Okay? So when is it actually a worry versus a focused interest? Okay? What do you do with these kids who are just kind of perseverative in general? I don't know if you guys have met these kids, but it's kind of like whatever you bring up, they're going to get stuck on. And this can mean if you're about to do a 100-page anxiety interview with them and ask them if they have all different types of anxiety, they're going to say yes to every single one of them, and they're going to talk a long time about it, okay? It might make them look like they actually have really severe GAD, when actually you realize if you had done an interview about Dasani water, they would seem to have a really intense perseveration about Dasani water, okay? It's not so much, it's more the way that they are as opposed to the topic. So we need to be careful about that before we assess severity of GAD. We also see in kids on the spectrum not generalized fear, but potentially circumscribed fear around their special interest, okay? So I am really into trains. Is anybody going to touch my trains today? What if they get moved? What if I run out of time for train time, right? I had kids who were waking up at 5 a.m. because they were worried they were going to miss out on train time at 6 p.m. that night, right? So they're anxiously worried, constantly, excessive worry, but it is not generalized at all. It is focused on their special interest. What do we do with that, okay? The other thing that often comes up in generalized anxiety is fears of change and novelty and negative reactions to change, right? So many kids with generalized anxiety are afraid of new things, but in kids on the spectrum we often see they don't have generalized anxiety, they just have a fear about the change, right? And you can see two presentations. One is worrying ahead of time. Will there be a change today? Are we taking a new route? What's going to happen? And just no worry ahead of time, but total meltdown when the change happens, which is probably the most ambiguous anxiety presentation that we could talk about today, okay? And finally, OCD, and I know I'm taking a little bit of time here, but I want to make you guys kind of see what we're doing in these interviews to parse out these things so you'll understand what's on the slides and how we think about these different things. So OCD is like the toughest, the absolute toughest. How do we determine OCD, compulsions and rituals from just repetitive behavior in ASD? And the things to think about here that we applied in the interview and that I got from Marty Franklin, who until recently ran the child OCD clinic at Penn, is that in OCD you want to think about the return serve, okay? So OCD basically sends a distressing thought or image into your head, horrible, uncomfortable feeling, and you need to do something to send it back. There's a specific relationship between the intrusive image or the obsession, right, and the response. So when you see compulsive behavior in OCD or ritualistic behavior in OCD, there's some connection to getting rid of a distressing feeling. And it's a very specific relationship. It has to be done in a certain way. And in that way, it is different than just self-soothing behavior, okay, like rocking or doing something over and over again to calm yourself down. And it's certainly quite different from other repetitive or kind of ritualistic behaviors we see in ASD that have positive affect, right? So another great thing that Marty always used to say to me is that when he got a referral for a kid to assess OCD, and when he asked what the obsession was, he heard it was trains, the red flags would go up, all right? Because trains, unless they're crushing someone or mutilating people, okay, are not typically the focus of obsession in OCD, but they are certainly the focus of circumscribed interest in autism. Okay, so there has to be negative affect here and a very specific relationship between the compulsion and the distressing feeling. All that being said, man, this is hard to assess just talking to the parent who's desperately trying to interpret their child's behavior, right? Okay. So all that I talked about, that's what we applied in this interview. Those are the guidelines. These are the different types of anxiety we tried to assess. And now I'm going to go back to the more boring kind of numbers part. But what I want you to take away from this slide is that we looked at the 2-week retest reliability of this new diagnostic approach, and we saw there was good stability over 2 weeks. So the diagnosticians were coming to the same conclusions in the vast majority of kids about what were the anxiety disorders they had 2 weeks later after they first assessed them, which is good, because if it's truly an anxiety disorder, we don't want it to be gone, magically gone in 2 weeks. That's not consistent with the presentation of anxiety disorder. We also saw, we checked inter-rater reliability in 25% of the sample. So what this means is that if I do the interview and you hear what parent has to say, we independently come to the same conclusions about what disorder this child has, okay? So we see good agreement across raters using this tool about making these decisions: anxiety, distinct anxiety, and autism. And this is just looking at the convergent and discriminant validity. So this shows you that the ratings of anxiety from the ADIS were significantly correlated with other measures of anxiety, the SCARED and the BASC. They were not significantly correlated with things like externalizing behavior or daily living skills. Again, this is good because those are different constructs. So we want to make sure it's not just catching all behavior, it's specifically catching anxiety behavior. And then only the ambiguous or distinct symptoms were associated with atypicality on the BASC, okay? So what did we find? I want you to look at the yellow first, okay, because this is important. 37% of these kids do not have anxiety disorders, okay? That's important. It is prevalent in this population, but we always need to remember there's a good chunk of kids, they're not anxious, they're okay, all right? 17% had traditional comorbid anxiety disorders, so DSM consistent, okay? We were so strict about you need to meet all the criteria in order to give these diagnoses. And being that strict, we saw 17%, they had classic social anxiety, they had classic generalized anxiety, okay? Another 31% had those classic anxiety disorders, and then they also had a distinct presentation, okay? So that would be the fear of men with beards, or it could be fears of change, worries about special interests, fearing social situations when you have no real fear of negative evaluation. These two things seem to go together for 31% of the sample. They're occurring together. And then 15% only had distinct presentations, right? So only that quirkier stuff. And what that means is, depending on what you want to call those distinct manifestations of anxiety, the prevalence or the rate of anxiety disorders in this sample changes by 15%, right? From 48% to up to 63%. So you can see the potential influence of deciding what we want to do with that category. We also saw that the traditional anxiety and the distinct anxiety had slightly different kind of associated characteristics in terms of what's associated with them clinically in the sample. So traditional anxiety was predicted by better language ability, more sensory sensitivity, and more anxious thoughts. This made a lot of sense. It was not associated with SRS, which is a measure of autism severity, or with IQ once you put language in the model, okay? So if I put IQ in alone, it probably would be predictive, but because language was in there, it's a better predictor than IQ broadly, okay? So, and this actually explained about 32% of the variance in traditional anxiety in the sample. If we look at these distinct ambiguous presentations, they're not associated with IQ, they're not associated with language. So what that means, is that the kid in this sample who had 67 IQ and the kid who had 158, because that was the amazing range that was in the sample, right? Both of them had distinct presentations of anxiety. So it takes us away from this interpretation that distinct anxiety is traditional anxiety in kids who don't have language to talk about anxiety. We actually see these distinct presentations across the IQ range, okay? Wasn't predicted by sensory sensitivity, but it was predicted by an anxious cognitive style and more autism symptoms. It was also significantly associated with the severity of their traditional anxiety, okay? So from this first study, it almost looked like these distinct symptoms were predicted by both autism and anxiety severity, right? The overlay of the two. Okay. We took this sample and then we just said, okay, how are these brief measures, things like the BASC, things like the SCARED, which is a 40-item anxiety assessment, and the pediatric anxiety rating scale. If we use the cutoffs that you're told to use to try and find the kids with anxiety in this sample, how do they do? So this is sensitivity, okay? A 1 would be we caught them all. The closer to 0, the worse it's doing. You can see that these measures do terribly, okay? So they're missing around 50% or more of kids with anxiety in this sample, okay, if you use the existing cutoffs. So then we just kind of wanted to experiment with it a little bit. So we said, okay, well, what would we have to do to these cutoffs to actually catch the kids who had anxiety disorders in this sample? And what you need to do is you need to drop them almost by half, okay? And look at this BASC child report. I mean, this is a 46. This is equivalent to handing somebody a BASC and immediately taking it away and saying, you got anxiety, okay? It means it's telling you almost nothing, all right? And similarly, even the SCARED, the typical cutoff is a total score of 25. You'd need to bring it down to 12 in order to capture the majority of kids who have anxiety in the sample, and then that really blows your specificity, so you're actually misidentifying kids at that point. So this, this was a small sample, but it was useful because this is actually a group of kids with autism who were not referred for anxiety problems or previously, there was no concern raised about anxiety. They were referred for some other reason. So if you want to think about how these measures do in catching anxiety in kids where it's not already suspected, this suggests not very well, okay? And these measures do better in treatment trials, okay? So trials where the parents are seeking anxiety treatment, these measures do better. Speaking of those treatment trials, this is data from the TASED trial, which is a terrible name, Treatment of Anxiety and Autism Spectrum Disorder. It's the largest randomized clinical trial to look at CBT's effectiveness in treating anxiety in kids on the spectrum. And I used this sample, the first 69 kids who were referred to the study. We actually checked the validity of this diagnostic approach that I was talking to you guys about further, okay? So I had some limitations in being able to talk about inter-rater reliability and retest the validity of the measure in this prior sample because there weren't that many kids with anxiety. So when you get down to the how many kids had the unusual fears and how good are we at getting that consistently, those are really small numbers, right? Because it was a total of 60. When you look at specific things, they're small. If you look at kids who are being referred for the largest CBT trial of anxiety and autism, you got a lot more to work with. So we used this sample to really test the measure again and make sure it has good reliability. People using it are going to come to the same kind of conclusions, and also understand a little bit about the rates of these different types of presentations in kids who are actually being referred for treatment. So what you can see, and again, this is just the first kids who were referred in the first year of the trial, so this is just a subset of the trial. But what you can see is that these pie charts already look really different, right? So, white is no anxiety disorder. So about 6% of kids who were referred for anxiety treatment trial, they don't actually have anxiety disorders, they had something else. Usually it's like ADHD or ODD. Some of them had just subclinical anxiety, but not every kid referred actually had an anxiety disorder. The vast majority, 92%, had these traditional anxiety disorders, okay? So this is almost the entire pie chart. They had generalized anxiety, social anxiety, separation anxiety. Within that, 46% also had the distinct fears, okay? And 2% only that distinct presentation. So you can see a real difference here, right? The types of kids who are going to be referred to this CBT trial, this would suggest, are predominantly kids who are manifesting this more classic presentation of anxiety. And yet, it's good to pay attention to this distinct stuff because it's actually in about 50% of the kids, right? And potentially it has a different response to CBT, or maybe it influences how CBT works. Maybe it's the primary concern for parents, more so than the social, okay? So it was interesting for us to see that even though the majority are being referred for traditional anxiety, distinct anxiety is still a part of the clinical picture here. And this study also let us look at the different rates of the different types of disorders within the sample. So generalized anxiety was the most common traditional anxiety, followed by specific phobia, social phobia, separation, and OCD. And these are all the distinct types of fears that I talked to you about. So about 29% had fears of change. 7% had just those negative reactions to change. I'm not sure if this is anxiety or not. Could just be poor emotion regulation. Okay. 3% had special interest fears, so really worrying about who's going to touch my stuff, or what if I don't get time to do it, okay? This has been consistent across all of the trials I've done. There's usually just a few kids who have it, but they're in every single study. Idiosyncratic phobias at 9%, and the ambiguous kind of social fear, the other social fears at 10. And what we also found in terms of our inter-rater reliability, which was much more robustly tested, is that inter-rater reliability, our ability to come to the same conclusions about diagnosis, was again good. The lowest reliability was actually for the specific phobias. So determining if your fear of needles is truly a disorder or not, it's hard for clinicians to agree about that, okay? They don't happen that often. So when you're trying to assess functional impairment, it can be tricky sometimes. But actually, these distinct fears, reliability was good, okay? We also saw, in terms of convergent discriminant validity, again, the traditional anxiety was associated with other measures of anxiety, so we see good, significant, positive relationship. Interestingly, ambiguous anxiety, this distinct anxiety in this sample was not, okay? Which is interesting, because remember, this is just the tail end of the distribution. This is all kids with really bad anxiety. In this sample, we didn't see that same relationship between the severity of the traditional anxiety and the distinct fears. We did see that those distinct fears were again significantly associated with the ADOS scores, so the severity of autism. And neither type of anxiety was associated with attention or aggression subscales, which is again good. It means that we're not just measuring more symptoms in general or a more complex profile in general. There's some specificity here. Okay. All right, and then I have just a few more slides. So this data isn't published yet, but I wanted to share it because it's interesting. So this is data just looking at the rates of these different things in a new sample. This is from the Autism Phenome Project at the Mind Institute, which is a longitudinal study that has looked at autism in kids starting at age 2, and the children are right around the 9 to 13-year-old range now. So they were not referred for anxiety again. They were just trying to get a representative sample of kids on the spectrum. And they had a real interest in anxiety, so I've been working with them to train them in the ADIS, the adapted ADIS, so they could assess the anxiety disorders in these kids. What's really cool about this sample is that it's the full IQ range of kids on the spectrum. So IQ in this sample, there are kids who are completely nonverbal. IQ ranges from 31 to 157, so even bigger. There were no child reports here, so this is just based on the parent interview. But this is what we're kind of seeing, okay? So this is our second sample, even broader in terms of IQ range, more narrow in terms of age range, where we're looking at what are the rates of these different types of anxiety disorders in the sample. And like this almost never happens in research, but this pie chart, guys, looks a lot like the first pie chart I showed you from 2014, which is like amazing. I really hope it doesn't fall apart, okay? But about a third, again, so it was about 37% in 2014 in the CHOP sample. This is about 32% do not have anxiety disorders. Not every kid with autism has an anxiety disorder. Okay. Traditional anxiety, about 22%, just that classic presentation. 27%, both. 19% just distinct. Okay. So again, depending on what you want to call that distinct stuff, it's going to change the estimate of anxiety disorder in the sample. And we also split it based on IQ, so above and under 70. And what you can see is, look, distinct anxiety is very similar in both groups, right? This is consistent with the first findings. Traditional anxiety is different, okay? So there is more traditional anxiety in the kids with IQ over 70 than those below 70. And I don't have this in a slide for you, but I'll just tell you, the kids who got diagnosed with traditional anxiety in this group, they only have specific phobias, OCD, and one case of separation anxiety. Okay? So there's no generalized anxiety in this group, and there wasn't social anxiety either. Okay? So it's very interesting because we've had these distinct, different results in terms of how is IQ related to anxiety. And one hypothesis we kind of put forward in 2012 is that IQ doesn't necessarily determine how much anxiety you have. Maybe it determines the quality of the anxiety you have. So kind as opposed to severity. Okay? And this would be consistent with that based on what we're seeing in this data. Okay? We also looked at sensitivity and specificity again of these brief measures. The scared, the mask, and the CBCL anxiety subscale. So these two are anxiety-specific measures. And what you can see is that sensitivity, again, is bad. It is better if you're just trying to use these measures to assess traditional anxiety disorders. And I should have said that for the first slide as well. Those terrible sensitivities I showed you? That was them those measures predicting just traditional. I didn't even put in the distinct stuff. If you look at their ability to capture distinct stuff, it's even worse, okay? So these measures do better in detecting traditional anxiety in this sample, but not in the lower IQ cases, okay? So it's missing almost all of the cases of anxiety in the lower IQ kids, which is interesting, right, because the anxiety presentation is more distinct in this population and characterized by phobias, which aren't really caught well in these measures. Okay? All right, so take-home points from all of this. I think we have some decent evidence now that there are both traditional and distinct and ambiguous presentations of anxiety symptoms in kids on the spectrum. We can reliably differentiate them from one another, from autism and from other constructs. We've demonstrated that in several studies now. And there are an array of these kind of distinct and ambiguous presentations, which we have kind of replicated across these studies again. There do seem to be specific categories, the ones that I talked to you guys about, of how these distinct anxieties kind of coming across. The 15 to 19% of youth, based on just these first initial studies, may only have that presentation. So depending on if you want to call that anxiety or not, it might influence how you treat them and also kind of our estimates of how much anxiety actually occurs in kids on the spectrum, and also what are the characteristics that are associated with anxiety in kids on the spectrum, because remember, they actually have distinct kind of profiles. The traditional anxiety estimates are right there where we actually see the best estimates from these overall studies, which is right around 40 to 50%. And so that's, again, consistent with the idea that the measures we have are probably better at capturing traditional constructs of anxiety than these more distinct flavors. Okay? If you include those distinct anxiety presentations, it's going to bring you to the higher end of the estimates. Traditional anxiety might be the thing that really brings kids to a CBT trial or brings them to treatment, but a lot of those kids are also going to have distinct presentations, okay? Which raises a lot of questions for us about what are the implications for treatment response. Is this something we want to treat with CBT? Will it respond to CBT? Will it reduce the effect of their ability to effectively treat generalized anxiety if they're co-occurring together? And is potentially, if we're not even recognizing these kids who have this distinct presentation, are we missing an opportunity to help them with anxiety, right? Because we're just thinking it's autism. So I have a little bit more hot off the presses data for you guys on that. So these are the initial results that I just started to work up from the CBT trial that I was talking about. So the final sample of treatment completers was 137. And just to give you guys some more background on this trial, it basically compared treatment as usual, which means the kids can go get treatment whatever treatment they want in the community, whatever they can get access to. Treatment as usual group compared to Coping Cat, which is just a standard CBT approach for child anxiety, and Bianca, which is a specialized CBT intervention. It's really been expanded and tailored for kids on the spectrum. So in addition to treating anxiety, there are social skills modules, there are modules about sensory stuff, repetitive behavior, behavior management. It's a much more intense treatment, okay? And we wanted to know what's the most effective treatment for anxiety, right? Are these CBTs better than treatment as usual? Do you need the supercharged autism-tailored approach to really have an effect and reduce anxiety in this population, how far could you just get with the standard approach? Which, by the way, a lot of mental health providers who are not familiar with autism, they might have some awareness of this treatment, coping cat, okay? So what you can see here, TAU is in green, coping cat is in this lighter green color, and Biaka is kind of our yellow neon, all right, is that Biaka did kind of win out, okay? So Biaka resulted in the greatest treatment response of kids over and above coping cat, but both coping cat and Biaka beat treatment as usual. And look at coping cat. It didn't do too bad. This is kind of a surprising result for many of us, that the standard treatment, unmodified, did so well, okay? When you look at remission response, so remission means no anxiety disorder at the end of treatment. Treatment, as usual, only 12% of kids went into remission, but it just shows you some did, okay? In coping cat, it was 48%. In Biaka, it was 57%, okay? And that 48 and 58% in terms of remission rates are not actually significantly different. So on that particular outcome measure, coping cat and Biaka did as well, okay? And then we looked at the distinct presentations too, which is what I wanted to do from like the get-go on this trial. This is why I'm engaged in this trial and train them all in it, because I really wanted to look at this result. Now this sample is smaller, because not all the kids in the sample, right, had distinct anxiety. It's only about half, okay? So that's why our margin of error is larger, okay? But we can see both coping cat and Biaka were effective, more effective than treatment as usual in treating distinct anxiety. So both of them actually got kids down to a lower level in terms of the severity of their anxiety. In terms of remission rates, 40% of kids in treatment as usual went into remission. So they didn't have distinct anxiety post-treatment that they did at the beginning, which is interesting, which suggests to me maybe that particular presentation is not as stable as some other anxiety disorders. We need to keep an eye on that. But even despite that, Biaka, the rates of remission in Biaka were around 76%, and that's significantly better than treatment as usual. Coping cat was right in the middle, remission was 69, and so it actually was not significantly different than either of these two things, okay? But you can see what the trend is here. All right, so those are kind of hot off the presses. I'm still delving into it. Again, take-home points. Traditional anxiety, I think, is the thing that is most consistent with true comorbidity of anxiety disorders in kids on the spectrum. I think we have some good evidence now that there are comorbid traditional anxiety disorders in kids on the spectrum. If you measure them carefully, they have a similar presentation, they have similar risk factors, and maybe those are the better candidates for treatments, although these clinical trial results are kind of promising. We also see this distinct and ambiguous anxiety, and there's a question of like, what is it, right? Autism, what category do we want to try and shove it into? Why are we even trying to do these kind of categorization things? That's not how life works. But we do try. What we see across studies is that they do seem to be more consistently related to autism symptoms. But again, these are not super high correlations. Okay? They're not 0.8, 0.9. It's not saying it's the same thing as autism. But it says it's related to autism. And we also see some things to suggest it's related to other characteristics associated with anxiety, and in some cases, the severity of anxiety. We did not see that in the clinical trial in kids where it was they all had traditional anxiety disorders. You don't see that relationship. But if you look at these studies where they're just referred because of the autism, the fact that they have traditional anxiety is going to be a decent predictor that they also might have distinct anxiety presentations as well, okay? And we also see consistent findings that these distinct presentations are not just traditional anxiety in kids who don't have as good language, right? So it's not just about if they can't verbally express their fear that they're going to have this more distinct presentation. We see the distinct presentations across the IQ range. We also see that these standard measures that a lot of us rely on because that's what we have, right, are not good at screening for anxiety in this population, and they're particularly not going to catch those distinct presentations. And that also, that's consistent with many other studies now. So both studies saying that the accuracy of self-report measures in general is questionable in this population, and also that studies, White and Medeiros here, have looked at the factor structure of the mask and the CBCL, and they're different. They're different in this population than they are in typically developing kids, okay? So there's some converging evidence here. We also see some support for this adapted interview, good reliability, a systematic way to differentiate traditional versus ambiguous symptoms, so you're capturing both. And I didn't mention this, but administration time once you're trained is about 2 hours. Although all the people I'm training on this right now don't believe me that that will ever happen. It's a long training process to really get this all in your head and figure out how to get through an interview, particularly with a talkative parent, quickly, right? But I promise you, the mean time was about 2 hours on the clinical trial, so it is possible to learn this approach and get pretty handy with it. And if we are starting to use an approach like this, maybe we can reduce this heterogeneity in all the research results. Maybe we can actually figure out what's related to distinct versus traditional anxiety and not mischaracterize autism symptoms as anxiety. That being said, limitations are, strengths we've had are well-characterized samples. Limitations are real limitations in terms of age, socioeconomic diversity. Something I'm really interested in is actually looking at preschool kids. Because by the time they're children, we know about 40% of them have anxiety disorder, and we know nothing about what's going on in the preschool age. So we don't actually have a good idea about when onset of these anxiety disorders occurs. So we need more diversity in our samples. We also need to think about, I have not been able to look at the ADIS in relation to actually tailored measures, continuous measures of anxiety in kids on the spectrum, because they were just developed. So now there are two. The Ask ASD and the PRAS ASD are two parent report questionnaires that were specifically developed and tailored to capture anxiety in kids on the spectrum and actually include some of these distinct presentations. So that's really cool. So I think that'll be a future direction. And in terms of other future research, I think it's these longitudinal studies. What predicts traditional versus distinct anxiety? I have this kind of hypothesis that distinct anxiety has to do with what anxiety looks like when you have particular characteristics of ASD, that ASD kind of changes the way it expresses, but haven't tested that yet, so we should probably do that. Looking at the treatment studies and also trying to clarify the association between traditional anxiety and other features. And I think that we have time for questions. I will just go quickly through this. These are some additional, the studies that we're kind of working on right now. So I'm continuing to work with the Mind Institute and the Autism Phenome Project to categorize these kids. We have started a preschool study to look at rates of different types of anxiety in young children on the spectrum with Kennedy Krieger Institute. We're trying to get funding from the NIH right now to do a follow-up of kids who are actually screened with the MCHAT early in life and identified with autism. We now want to follow up and see, number one, did we miss kids who actually have autism even when we use this universal screener? And number two, what are the rates of psychiatric comorbidity in this sample? And can we use some of this earlier data to predict who are the kids who are going to have anxiety at this follow-up assessment? And I'm also very lucky to be working with Dr. Miranda on the Pathways Project, which is like this really amazing Canadian longitudinal study. And so we're really interested in looking potentially in the next phase of Pathways. This is just research ideas to be explored, better assessing anxiety and comorbidity in adults on the spectrum. So all this work has been focused on children, certainly needs to be applied to adults as well. And then we would have a huge wealth of information to really look at the trajectory of anxiety over time and what would predict high rates of comorbidity in adults. All right, and there's somebody at UNC who's actually looking at this in kids with Fragile X. So I've really debated about what to call the distinct anxiety symptoms. You might see it if you look at any of my papers, like some of them say atypical anxiety, some of them say ambiguous anxiety. Some people have tried to call me autism anxiety, like ASD, but I don't think that's correct because I have no proof that this is just in kids with autism, right? But by looking at this in children with Fragile X, that's a way to kind of explore it, right? If we started to look at this in kids with ADHD, we could see, is it really something specific about autism, or are there certain characteristics associated with autism you actually see in broad populations that are associated with this kind of manifestation? These are the treatment trials that are going on. We're still working on TASE. This is a trial that's comparing CBT to MED for kids on the spectrum. That's being done at UC Davis, and I'm working with as well. This is a study of asking community providers, do you treat anxiety? What strategies do you use to treat it? And we actually, knowing that most community providers are not necessarily clinical psychologists, spent a lot of time developing this survey by getting experts in behavioral analysis, in speech and language pathology, in OT, nurse practitioners, education, all the different disciplines, asking them what are the words you use to describe treatment. Because what I might call exposure and response prevention, somebody else might just call habituation, right, or desensitization. We have different languages in all these different disciplines. So we did a lot of work to try and speak to this really broad, diverse community sample and ask community providers, what are you doing what are kids asking for in terms of treatment, and what strategies are you using to help them? What do you think is useful? And we're also interested in potentially looking at prevention programs. So if we could figure out what's leading to anxiety, maybe we could actually prevent or do early intervention. The other final area is adversity and trauma in kids on the spectrum, which I didn't even get to talk about today, but it's a little bit there when we think about social anxiety, right? And is this an appropriate or inappropriate concern? We need a lot better understanding of what is an adversity, what is a potentially traumatic event for somebody on the spectrum, and how does that relate to this super high rate of psychiatric comorbidity that we see by the time they're in teenage and adult years. Okay. And this is paper dog or black dog, which was one of the fears that one of my patients who was 8 had. This is a cardboard cutout that they put in campsites to scare away pigeons. He was absolutely terrified of them. His mom really got CBT though, so she ordered it online, set it up in their kitchen, and his homework for CBT each night was to add something to black dog or paper dog. So you can see that he gave him an eye, a collar, a bone, teeth, and finally black dog, no fear, okay? So this was my soul sister kid as well, okay? He had more idiosyncratic phobias. We applied CBT at the time experimentally. I had the conversation with parent. It did seem to work. However, we often found that if you removed exposure to the stimulus, the fear would come back. And it did take him longer to habituate. So even though we're seeing these positive response in the TASE trial, there's a lot more to learn there about what's actually going on in the treatment and what are the strategies that are working, how habituation works in response to these things. There's much to explore. Okay, that's it.
We have a few minutes for questions.
Yeah, I'm happy to take questions. Yeah.
There's one.
I have like 1,000. I'll stick to this here. So just basically, do you have any anticipation that you'll release the what are you calling it, modified ADIS?
Yeah.
For clinician use in the future?
Yes, so here's the deal. I'm in conversations with Oxford, who published the original ADIS. The ADIS 5 is coming out, and there's supposed to be the autism version, the ASDD protocol, that will be published as well.
But not your version?
It is.
Oh, it's your version.
Yeah, it's what's in here, but instead, so literally what we were doing in these studies is we had the ADIS here, and then I would shove little pieces of paper in between the existing protocol to tell the research clinicians what to do about how to make, so instead of having to shove pieces of paper in, there will actually be something printed that's an integrated protocol. That's the ADIS for ASDD is what we're calling it. However, the only caveat is I'll just tell you this is something I've been talking about with them for 3 years now, and I have yet to see it in my hands. So I am told that it's going to be published, but that's kind of an ongoing process. In the interim, I do train people on it for research studies, and I have done training for clinicians at INSAR 1 year, and it's something I'm open to doing again, particularly if there's a critical mass in BC who would be interested in this and want to get trained on this. That's something we could think about doing now that I'm here in my lab. I'm also training the people in my lab on it. They need to learn this. So we could all do it together if it's something that you're interested in. It just depends on how much interest there is. I require a different level of training if you're going to be using it for a research study than if you're going to be using it clinically, just like the ADOS. So if you want to do it research-wise, you kind of have to get checked out, and we need to make sure it's reliable before you go forward to do that. But there are some options.
Questions?
I know I didn't explain it perfectly, guys, so. Yes?
Do you see a difference between males and females in pregnancy?
Nothing yet, but there have been, research excluding the last couple of years has generally not found a gender difference. But in the last few years, there are some studies popping up that do suggest a gender difference. So, for example, I just looked at the National Survey of Children's Health, which is a population-based survey in the US, and looked at the rates of anxiety being reported by parents of kids on the spectrum. This is not the ADIS, okay? This is a one-item, ask the parent, has somebody told you that your kid has anxiety? But what we did see actually a gender difference there. of more parents of girls on the spectrum saying that they had also been diagnosed with an anxiety disorder. And what's kind of interesting about that is that this cohort of kids on the spectrum has also been changing, right, in the last 5 to 10 years. So all of a sudden we're actually including more females. We're including more individuals with higher IQ and less severe kind of presentation. So if that holds and we actually start to see a difference, that would be something I would be interested in looking at as potentially related, right? Is if our expansion of what autism is and what it looks like in women on the spectrum is also allowing us to capture women who maybe haven't been identified and have a lot of anxiety associated with that. All hypotheses though, so.
I know from studies about friendship and autism that females have more social motivation than males, right?
Right, and so that's where, when there's anxiety broad, and then there's all these subtleties, right? So it may be that we're particularly likely to see social anxiety, generalized anxiety in that group, if they are more socially motivated, if they are more aware of their differences, right? As opposed to the distinct presentations, which might be more evenly distributed. But, the problem with research in autism on females is that because of the way it's been defined and how we've captured it for long, those female samples tend to be very, very small, which prevents you from being often able to find these differences. So it'll be really, really interesting next few years, I think, yeah.
So I'm wondering if you have anything to say about other anxiety disorders. In particular, I'm thinking of agoraphobia/panic disorder.
Yeah.
I was a bit surprised that it's not part of the mix of what you're looking at, because I don't know,
So the reason it's not there is it's hardly ever endorsed. So it just hasn't come up in child studies. In general, agoraphobia and panic are less frequently diagnosed in children. So the onset of those disorders is typically more later teenage years and early adulthood. The closest thing I've seen to agoraphobia has actually been in this autism phenome project in the really impaired kids. They have just a lot of difficult behavior in general, and sometimes it can translate to a refusal to leave their home, and also the family is just too overwhelmed to leave the home, and there's kind of anxiety about anything outside of the controlled environment. Now again, if that's truly agoraphobia, as we think about it in an adult who has agoraphobia because they're afraid that if they leave their house they're going to have a panic attack, right, and they won't be able to get to safety. That's how we usually think about agoraphobia. I don't know if those are quite the same things. But that's the closest thing I've seen to it, which is that I have seen in some of these severe cases, they don't want to leave the house, they don't want to leave the controlled environment, and certainly anxiety seems to be a part of that.
But what about, so forget the agoraphobia.
The panic?
The panic disorder. I mean, I've heard people say, that the kid who has a meltdown in, used to be Kmart doesn't exist anymore. Kid who has a meltdown in Walmart, maybe he's having a panic attack.
Yeah. So I would say,
first of all, differentiation.
Right. So first of all, panic attack and panic disorder are not the same thing. Okay. So panic disorder is only diagnosed if you're somebody who has panic attacks, and then you develop a fear that you're going to have a panic attack and you won't be okay. And so you're actually worried. It's the worry about having the panic attacks. Plenty of people with generalized anxiety will have panic attacks, but they don't have panic disorder. It's just basically the anxiety kind of takes over their body and they have a meltdown, and we wouldn't call that panic disorder. So because there's this precise definition of panic disorder, that's been pretty hard to assess in this population. And again, I've mostly looked at kids and teenagers, and it hasn't been endorsed. So there might be I know there's some subclinical panic that we've seen in these studies, but nobody's kind of made it to the disorder diagnosis. That could be very different in adults. But I wouldn't say a meltdown, being overwhelmed by emotion, is not the same thing as panic disorder. Yeah. Right, yeah.
I was really curious, and I wonder if I misunderstood. Would you mind going back a couple of slides when you were showing I think you were hot off your press.
The treatment study?
Yeah.
Yeah.
Did you say that the rates of, I don't know if you called it remission or...
Yeah, I didn't put them up here.
No, but they were quite high, right? They were in the 40% or
So treatment as usual, 40% of the kids no longer had distinct anxiety at post-treatment. And then here it was 69% and 78%, yeah.
Which is very high and quite, but then it made me wonder, looking at the graphs, does that mean that other children are developing, if we look at, it's pretty flat, that turquoise bar,
Mhm.
so if 40% are no longer presenting with that, so I guess I was just.
This is a mean, so
Right.
these are mean readings, and then remission is like they no longer had that specific disorder, so
Right.
it's different numbers, yeah.
But for the means to stay the same with 40%?
Because, right, how could that possibly
How could
happen?
that be?
Okay,
Yes,
because
thank you.
remission is moving, remember this clinical severity rating is 0 to 8, and the cut point for diagnosis is 4. So you could go into remission by going from 4 to 3, which is almost no movement on this scale, but technically moves you from having an anxiety disorder to not having one. Does that make sense? So I think that's what's happening, and particularly these, again, I haven't been able to really dig into these, but I'm particularly interested in these idiosyncratic phobias, their stability, and their likelihood of being considered, yes, impairing, this is a disorder at one point in time, and then actually, no, he's kind of doing better with that, it hasn't been coming up so much, so it's not as big a problem. So I think we need to look at that. And there's also just some of this kind of historical, like Connor talks about those idiosyncratic phobias in the original 1943 article, and one thing he says about them at that time is actually it would vacillate between phobia and obsession. Obsession in the positive, not OCD way, in the perseveration, especially like I am obsessed with the weather, I love the weather, I'm researching the weather, to total like phobic avoidance, freaked out by storm clouds or something like that. So vacillating between those two things in this population. And so what I haven't been able to do is really look at what were the specific disorders in this distinct category. So limitations of this research, I'm showing you guys kind of overall ratings, what's the most severe type of traditional anxiety, what's the most severe type of distinct anxiety. That might be not the best thing to do, to shove all these distinct presentations together and pretend they're the same thing. You know, they potentially have different responses. So maybe one type of distinct anxiety is going to respond better to CBT than another. But I just didn't have the numbers to really look at that in this study. I was happy to be able to look at it at all. But that's why this line looks not significant, but we can see the bigger rate in terms of change in remission.
But it's also not that if there's another 40% who now have scores that would, so that's what I was curious about, the stability piece of the children who did meet criteria. So.
Oh wait, and you know what, sorry, I need to just adjust myself. This is the TAU line. So this is the, yeah, this is the 40%. Right, sorry, Coping Cat did better. Yeah, so this is, there was one new case of distinct anxiety. Mostly not. I have that in another slide that I didn't include here, but there were some new onset cases. They're small slivers, they're not a lot. Yeah.
Other questions? We okay? Good, well, help me thank Dr. Kerns one more time.